Hi, hello. Thank you for joining us. Welcome to the second of Mountain Valley's webinar series. I'm Everett Logan. I'm the Executive Director here at Mountain Valley Treatment Center. Today, we're going to be talking about reversing the anxiety cycle with exposure and response prevention. We're joined today by Ashley Metz, who is one of our clinicians, formerly our program director, and Dr. Tim DiGiacomo, who is our clinical director. So they're going to be talking a little bit about how ERP works, how it helps reverse the cycle of retreat and withdrawal that many people suffering with anxiety and related disorders go through. So without further ado, I'll let Ashley and Tim tell you more about ERP and how that helps address people with anxiety disorders.
Thank you. I guess I'll start. Or
Sure.
Yeah. I think it makes sense to first define what anxiety is. Of course, we all have anxiety. It's normal. The kiddos, youth, residents we work with have what we would call abnormal anxiety. And really, it's about how that anxiety is impacting your functioning. So with normal anxiety, of course, it can help us prepare for things like a webinar. Abnormal anxiety might look more like staying up till 3 a.m. preparing for this webinar. So our definition of anxiety that we like to use at Mountain Valley is the overestimation of a perceived threat. The threat does not have to be real. It's how we perceive it. And our underestimation of our ability to cope with that perceived threat.
Yeah, I think you bring up a good point too about anxiety being normal, abnormal, or even adaptive or maladaptive, right? So you stated that everyone experiences anxiety, right? And to a degree, that can be helpful, that can be adaptive, that can help you to prepare. There is an anxiety performance curve. So you spend enough time preparing for a presentation or a talk or working on your schoolwork or something else, right? But after a while, you peak, right? And then your performance starts to drop when your anxiety is continuing to be at such a high level. And again, then it often leads to that retreat and withdrawal and avoidance, right? Experiential avoidance. And that could be of situations, that could be of objects, that could be of people, that could be of even trying to get rid of like internal feeling states, right? This sort of a fear of anxiety, or interpretation that anxiety is a bad thing, right? The work that we're doing here at Mountain Valley is really trying to reverse that, right? And when you're thinking about the anxiety maintenance cycle that we teach all of our residents, there's that what Ashley was saying. There's the trigger or stimulus, right? The situation that provokes anxiety. And again, what is that? That's the overestimation of danger or threat, and the underestimation of our ability to cope. And then often what happens is people avoid, right? People who are really suffering from severe impairing anxiety, they avoid. Or if you're working with families, that's also where family accommodation occurs, right? Or even other groups, people who are well-intentioned and trying to help, but instead of allowing the person with anxiety to stay in the situation and work through it, they do things that actually help them to avoid it. And that maintains the anxiety. So with exposure therapy, the key component there is actually the key opportunity is at that point. So instead of adapting, we're teaching people how to confront their fear, how to actually engage.
Right. When you avoid the anxiety, you're essentially reinforcing in your brain that specific thing is dangerous. So say I avoided this webinar today, I am telling my amygdala essentially that the next time a situation like this comes up, it's going to send out those fight or flight signals. So with the exposure, essentially the goal is to develop it's like a learning opportunity to pair a new learned association with this fear situation. So instead of it being a scary thing, we're learning that it is something, one, that we can do and tolerate, and two, that it's not as scary as we might have thought. Sense.
Yeah, so we're going back again to that definition of so the overestimation, that we're really testing that out. So by staying in situations for an extended period of time and doing so repeatedly, right? We're, as Ashley said, we're learning, we're getting new information about how we can respond, how we can interact with those situations, right? Those anxiety producing situations. And then we can learn maybe that, maybe it wasn't as bad as we thought. Maybe the worst case scenario did not occur. Maybe it did actually occur and we were still able to get through it, right? And what did we do to get through it? So again, it just keeps going back. This whole idea of confronting your fears. So we're not going to be distracting ourselves. We're not going to be trying to pull away from these anxiety inducing situations. We're just going to say we're really going to lean into those. We're going to engage with them.
Tim, how do you define generally as a professional? As Ashley mentioned, anxiety is a normal human emotion. All of us experience anxiety. We don't all have an anxiety disorder. In broad strokes, how do you define when someone is now considered to have a disorder with regard to anxiety?
Yeah, and I think if you're talking more diagnostically, right? One of the main components across disorders is that it's got to be functionally impairing, right? So again, everybody experiences anxiety, but it's those for whom it is limiting or inhibiting their ability to do things that are sort of expected of them, that are age expected, age appropriate, things that impact, like if their anxiety is impacting their ability to go to school, for adults, go to work, right? Take care of their home, do things like your basic ADLs, taking care of yourself. So that's really how I look at it.
Right. And that's kind of where, how these residents that we work with end up here, is that lack of functioning, I'll say. So to talk a little bit more about what we see at Mountain Valley, typically for anxiety, a lot of kids not going to school is a perfect example of that avoidance, and how it reinforces and often increases the anxiety. The less they go to school, the harder it is to go. We see also pretty related to that, social anxiety. They can be pretty intertwined. Sometimes it's more about the academic work. Sometimes it's about the social dynamics. We see some specific phobias, animal-related fears, health anxieties, whether that's bugs, fear of getting a disease, things like that. Am I missing anything?
Yeah, I'd also say when we talk about anxiety and exposure work, also with OCD, unwanted intrusive thoughts or unwanted internal experiences, right? Where people are often trying to avoid and push those away. I think the more that people do avoid, the stronger those associations are that, yeah, this is something I should be afraid of, right? So again, if we move into then how do we actually use exposure therapy here, Mountain Valley, it really starts with a strong assessment, a good functional assessment, where we're really trying to target and understand what is it that someone fears. So Ashley brought up this idea of school refusal or school related anxieties, and what is that really about? Is that about judgment from peers? Is that judgment from teachers? Is that being in other certain social situations? Is it just afraid of being in the hallway surrounded by people? Is it that I'm going to go to school and I'll feel overwhelmed and experience a panic attack, right? And what will people think about that? Or just the feeling of I can't handle that, right? So with a functional assessment, we really want to drill down on what is it that is making the person anxious. And as we're able to get more information and we're better able to target it through specific exposure work, right? So, you know, for something like panic, actually, if someone's saying, you know, I'm interpreting physical symptoms as indicating that I'm going to have a panic attack or as something catastrophic, right? We want to help them to be able to actually recreate those symptoms and change their relationship with them, their interpretation and understanding of it. And that's by doing. So, you know, exposure work is, you know, obviously it involves talking as in traditional psychotherapy, but there's also a very strong behavioral piece to it, right? We're really focusing on the going and doing, you know, identifying what it is that makes us afraid and then confronting it.
And I think it's really important to also emphasize that this is not so much therapist driven, it's very much collaborative. Exposure therapy should never be something we force people to do. They should have the buy-in. One, to make it most effective, so we know that they are willing to fully immerse themselves in the experience without those safety behaviors. And two, from an ethical standpoint, of course, it's got to come from within to really make it effective.
Yeah, you're bringing up, I think, two important concepts there. It's the first being willingness, right? Well, I'd say three actually. It's willingness, collaboration, and then this idea of safety behaviors, which we can get into. But yeah, this is not a therapy that is just simply directed by a therapist. You know, we're not just making sort of we're saying you need to do this, right? There's always sort of a challenge by a choice, right? And so when we're working with our residents and they're saying, this is what I'm afraid of, right? Then it's our job to work with them and say, well, here's how we can start to try to recreate that or to more closely approximate getting you there, right? And so oftentimes exposure work, good exposure work is done in a gradual way, right? As much as it can be. You can also do more of a flooding type exposure, which sometimes that happens naturally. So sometimes when residents, you know, who maybe have severe separation anxiety, right? Sometimes when they come here, they probably do feel flooded.
That is the biggest exposure.
And overwhelmed, right? And there are still ways to gradually work someone up to that, right? Helping them to, you know, before they come to treatment, you know, imagine what it's going to be like. You know, have more conversations about that, be thinking about it. So trying to put themselves in that exposure without actually being in it in vivo or in reality, right? So there's the imaginal exposure piece that you can use that can help with some of that flooding. But ideally, we're trying to do things gradually, right? And that can help with motivation to continue with exposure work. That can help with you know, ongoing adherence to engaging in treatment.
Building confidence.
Right, it can build confidence and help people to then think, okay, well, I could do this, and that was, you know, I thought that was pretty hard. I anticipated this situation to be incredibly anxiety provoking, and you know, it actually wasn't so bad, or that was really tough, and wow, I still got through it, right? So it can then build confidence and momentum and greater willingness to then try harder things, right? Or what they anticipate to be harder things. So, you know, I think the role of clinicians and the staff here is helping identify those opportunities for exposure work and other ways to get at the fears, and then being supportive, right? Being encouraging, being a cheerleader. And that's different than providing reassurance, right? That's different than saying everything's going to be okay. It's different than saying there's nothing to worry about, right? Those are some of like the more damaging things to do. And that ties into your point about safety behaviors, right? So maybe you can describe what a safety behavior,
Yeah.
or safety seeking behavior actually is.
And can you, while you're doing that, can you also define how, well, can you explain how do we tell the difference between a safety behavior versus an appropriate coping mechanism?
Yeah.
Because sometimes that can be the same behavior, but it's very context specific.
Yeah, yeah, it can be a fine line. So safety behaviors, essentially it's any behavior one might use that mitigates the anxiety they experience throughout the exposure. So, for OCD, that could be a compulsion. It's even though they're in the exposure, they're still doing the thing. It's not really allowing them to fully experience the distress that we're hoping they learn is tolerable. Majority of the times, what we see a lot here is just straight up avoidance. That in itself is a safety behavior. More subtleties might be, somebody giving a presentation and, not looking at the audience, or maybe holding note cards. For panic, it might be holding on to a Xanax in case they have the panic attack, so they know they are safe, but not actually using it. And that really obstructs the learning process, because they're doing it with these aids, essentially. Safety behaviors can also sometimes be coping skills, like you're saying, and it's a really fine line. Something that our residential staff often find challenging, especially in the milieu, is, we're doing this art activity and someone with perfectionism is having a really hard time. So they might ask to use a coping skill, such as reading or journaling for 10 minutes. If that skill is used for an extended period of time, and if that person does not re-engage with the thing that's challenging, that is when it becomes a safety behavior versus a coping skill.
So again, it goes back to functioning, right? So it goes back to functionality, and how does engaging in any behavior help you to actually do the thing that you set out to do, right? The thing that you intended to do or need to do.
Think of listening to music being a big one. You just went through something really hard. It was really stressful. It took a lot of energy. So now I'm going to take a break and sit down and listen to my favorite music. That's an appropriate coping skill. Putting on your headphones when you're supposed to be in class as a way to tune out what's going on around you is a safety behavior, right? Both listening to music, but used in a different way.
Exactly.
Right. And if you look at that from the standpoint of the anxiety maintenance cycle, listening music to zone out and to avoid the thing that's happening in class that's making you nervous. In that moment, your anxiety might go down, right? But when the teacher calls on you and says, hey, you need to take those, earbuds out, and you do, and you haven't been listening, and now you don't know where everyone is in class or on the assignment or what to do, your anxiety is going to spike again, right? So it's not a good long-term fix, that idea of avoidance or engaging in safety behavior. Yeah.
And that is why we have our Mountain Valley motto, sit with it, really emphasizing that the goal is to sit with the discomfort and, fully sit with it, immerse yourself in it, rather than all these little things that we're talking about.
And that was actually one of the things I was going to ask you about, is this idea that we talk a lot about how you don't always have to change an emotion or push the emotion away. Can you talk about some of the benefits that occur over time when you learn to sit with your emotions rather than avoid them or push them away? What happens to you when you learn to do that?
Yeah, and part of that is you talking more about that idea of experiential avoidance, right? So it doesn't have to just be avoidance of, like you said, like a person or situation, but trying to push away anxiety or, people who say, I'm feeling bored, right? I can't be bored. I can't just sit still and just sort of be myself or in my thoughts, because that's too distressing, right? So the same approach that the exposure approach applies there as well, in terms of helping people to get more in touch and attuned with a thought can just be a thought, right?
Mhm.
A thought can lead to certain feeling states that might be unpleasant. And can you still take that with you and go about your day and do things that are important and
Mhm.
meaningful for you,
Mhm.
right? We're talking about exposure therapy here, but if you also then look at components of acceptance and commitment therapy, there's a big focus on living your valued life. So, what have you identified what your values are? Like what, have you sort of authored those and put them out there?
Mhm.
And are you making choices that are moving you closer to those or farther away
Mhm.
from those, right? And so learning how to sit with and experience things that are unpleasant at times, if it's still moving you towards your values, that can be, that can be life-changing.
Mhm.
That can be a big game changer.
Yeah, and the avoidance, whether it's behavioral or emotional, it makes one's life very small in that,
Right.
behaviorally, you have much less opportunity to engage when your anxiety is running the show, and emotionally, avoiding the internal experience often leads to not experiencing the more positive emotions as well. Almost like numbing yourself to all emotions. And what kind of life is that?
Yeah. Yeah, I want to be able to experience sadness. I want to be able to experience anxiety. That can give me information about what's important to me or what's meaningful, just as much as when I feel happy or when I feel joy
Mhm.
or excited about something. Um, you want to be able to be accessing all of those emotions.
Mhm.
Great. I want to allow some time if folks out there have questions, you can type them into the chat function and they'll get passed along to me and I can pass them on to you. I guess one question I'll start with and is when someone has done ERP for a while and they're starting, you talked a lot about gaining confidence and being able to implement their skills. So certainly gaining more confidence is a good thing and feeling that you're able to confront your anxiety through repetition of this. What will be the effect on that initial anxiety response? Will that change as well? Or is it just that they get better at dealing with it?
Yeah, I think with exposure work that's done well. So there's that repetition and there is that increasing duration of time. There's generalizing by engaging in or confronting those fears in different situations, right? So you're really trying to push for what's this idea of like an exposure lifestyle.
Mhm.
And so you want people to then be taking on the naturally occurring opportunities to confront their fears.
Mhm.
And so, the more someone's able to do that, the more they are able to see that they can live their life, right? And that anxiety doesn't have to have that hold on them. One of the older ways of thinking about exposure work focused more on that idea of habituation with reduction in fear within therapy sessions and then across therapy sessions. The idea would be that your anxiety spikes and then drops down in a session and then starts lower the next session and drops down. But what we find is that that doesn't always work, right? That doesn't always bear out. So the other way of focusing on this or looking at this is more the learning piece, right? So the more opportunities you have that you're confronting and engaging with the things that provoke anxiety, the more you're able to learn, right? So that doesn't get rid of your old learning about the fear, but adds newer learning, right? That like maybe I can be okay in this situation. It was all right, and that can then help with reinterpreting those feelings of anxiety, so that it's like, okay, maybe I'm feeling anxious, but maybe that's a false alarm right now, right? And if I think to sure, there were some scary times in the past, and I've also got evidence from all of these other situations that like I made it through those okay, and I did so, sort of independently, right? Or without engaging in a compulsion or without engaging in some sort of safety behavior.
Mhm.
And I'm moving towards what's important to me.
Mhm. Yeah, I think when the goal is the habituation, if that's the goal, it often can reinforce that anxiety is bad, which is just further evidence for the more learning approach.
Right, and when that idea of anxiety sensitivity.
Yeah.
And we don't want people to be thinking that anxiety is a bad thing.
A few more questions. Can ERP be used for unpleasant, intrusive thoughts as opposed to situations or things?
Yes.
Absolutely. And that's often what we see with OCD, these unwanted intrusive thoughts. And, the exposure can often, if not always, it's not about exposing yourself to the thing, it's about exposing yourself to the anxiety or the intrusive thoughts. So the exposure when planning them would be, it's intentional to trigger those. And then that same learning process occurs. As with anxiety, usually unwanted intrusive thoughts result in anxiety, but you're really learning to tolerate those intrusive thoughts.
And I was just going to say, just by nature, you can't control, they're called unwanted and intrusive for a reason. You can't control when you're going to experience them or not, right? And oftentimes, especially with OCD, but also with anxiety, people are then engaging in some sort of avoidance or trying to push it away. And I think most of us maybe have, sort of done the white bear exercise, don't think about a white bear. Okay. Take 30 seconds and don't think about your breathing, right? That's all you're going to think about, right? We can't not think about it. And so the exposure work is more about, you could be doing things like writing it out. You could be talking about it and then not engaging in some sort of safety seeking behavior. So there's a lot of ways of using exposure work for unwanted intrusive thoughts.
So another question, which is sort of a natural segue, is asking how does ERP apply to OCD?
I think the underlying premise is very, very similar. Like you think of the OCD maintenance cycle, and it's very similar in that there's an anxiety-inducing situation, and the safety behavior in this case would be the compulsive behavior. So therefore, it's reinforcing that those obsessional thoughts, obsessional thinking are scary and dangerous. And again, we're trying to reverse that. So
yeah, engaging in a compulsion is just another form of avoidance. So I feel distressed. I engage in a compulsion that reduces my distress. It also robs me of an opportunity to actually see what happens, right? So if I'm experiencing an unwanted intrusive thought that, I just walked in the kitchen and I saw a knife and I had this thought of, oh my God, I just saw it, like I need to leave because what if I grab that knife and hurt someone, right? It says thinking more of like a harm OCD. Well, my compulsion would be leave it, right? It's avoidance. Or my compulsion might be saying a prayer 10 times in a certain way, right? In order to keep myself from hurting anybody. By not doing that, it makes me confront that fear. And that's incredibly scary. That's incredibly challenging work. And it's also necessary if you want to be able to work through the OCD. Otherwise, you're going to end up avoiding kitchens, and avoiding knives, and avoiding people you love. And that's not really, for most people, that's not the life that they want to live. It's not living according to what's important to them and their values.
Right. Could ERP trigger a different type of anxiety or bring on new fears?
it's possible. Absolutely.
And I think when people are engaging in any sort of therapeutic exposure, I think this is partly why I'm trying to read into the question a little bit. If someone is engaging in the exposure work and they feel like it's going at a pace that they're not up for, right? Then I think they may experience, or if there hasn't been enough good like role induction explanation of how to do the exposure work or the purpose of the rationale, then they might become more discouraged, right? Or they may say, wow, that terrible thing happened. The worst case scenario happened. And that just solidifies for me that like, I can't handle this, right? So I don't know if that's necessarily a new fear or just, it makes it a little more harder for them to engage. And I think that's where working so collaboratively with your clients is really important. And being able to sort of engage in some repair work and motivational interviewing to help people who are doing this kind of work to stick with it, right? And then, sometimes people with anxiety, sometimes the anxieties change, right? With OCD, sometimes we'll see that change as well, right? So there could be sort of harm OCD, but then there's some other new obsessional content comes up or different compulsions, or it's mixed in with scrupulosity or something else. But I think that's still not a reason to not engage in ERP. ERP is really the gold standard for anxiety and OCD.
Given the signal that it's about time to wrap up, Ashley and Tim, thank you very much.
Thank you.
I want to thank everybody for joining us. If you do have other questions about anxiety, OCD related disorders, ERP and how it relates to it, or anything else in regard to anxiety treatment, please feel free to contact us. You can find all of our contact info on our website, which is www.mountainvalleytreatment.org. And we'd be happy to hear from you anytime. Thank you again for joining us.
Thank you.